Welcome to Prescribed, Clinical Exercise in Practice, a video interview series from WorkoutLabs, where we talk with clinicians shaping the future of clinical exercise programs.
Hi, welcome to the first episode of Prescribed. I'm William Artamon, the founder of WorkoutLabs, and today I'm joined by Betsy Hart, Program Supervisor of Cardiopulmonary Rehab at MacNeal Hospital, Fellow of the AACVPR, and one of the most active voices in cardiac rehab community. So Betsy, welcome. We're super excited to have you in our first episode.
Thank you. I'm excited to be here. My first podcast.
That's awesome for us too. Those who aren't familiar with you yet, tell us just a bit about your background and how you ended up doing what you're involved in today.
Sure. I just celebrated my 20-year anniversary working in cardiac rehab. I've been very privileged to do this in the same space for a long time, which is a gift for sure. I did my undergrad at Benedictine University in nutrition and then my master's in exercise physiology, and most of my classmates were going to do cardiac rehab, so I said I'm for sure not going to do that because that's what everybody else is doing and I don't like to do what anyone else is doing. So I spent 5 years doing bariatrics, which was really cool, working with patients before and after gastric bypass. And then I was looking to shift and do something different. And there was a job opening in cardiac rehab. And I'm like, well, I'll do that, just a year or two while I'm looking for something else. And I started doing it and quickly came home and was just like, oh my gosh, I love it so much. I can't believe I have to admit that, this is what I said I wouldn't do. And it's become 100% my favorite thing. Very passionate about it. But it was funny because that was one of the paths going in from grad school. A lot of exercise physiologists at the time would either go into cardiac rehab or stress testing. And I, of course, was like, I'm going to be different. I'm going to do something unique. And just absolutely fell in love with it and have been doing cardiac rehab now for, like I said, for 20 years. Yeah, I'm very happy to be doing what I'm doing. And I think, it's hard to do any job over a long period of time, but I think if you don't really love what you're doing, the days are really long. And I think for me, I have loved doing what I'm doing for so long that the days, for the most part, feel very short and go by quickly. So yeah, it's been a privilege to do this with others that also have a big passion. I think that's one unique thing about cardiac rehab is we're all very passionate about what we do.
I noticed all the annual meetings and just when clinicians get together, everyone is so warm to each other and just they love working with those patients. If you had to mention one thing that you love most about cardiac rehab and working with the patients that you do, what would that be?
I think for me, usually when someone says, well, why did you decide to do cardiac rehab instead of stress testing? And for me, I think it's the journey. I think those of us that like a story, we like to see the before and after. We like to meet a patient who's maybe really struggling. And I think my favorite thing is seeing their journey and knowing that we were a small part of that. And I love the really ornery, angry patients that just come in and the daughter is saying, I'm so sorry, my dad was so difficult with you. And I say, no, I love those patients. I love the ones that are surly and angry and just telling you all the things that they hate about being there. And I always say, quietly either to their significant other or whoever's brought them, I said, they'll be bringing me cookies on their last day. They're going to not want to leave. And that's my favorite part is kind of turning them from, maybe not quite fully accepting of what's happened to them or afraid. A lot of it is the feelings and emotions that they're still struggling with after their event. And we just get to be there to kind of support them as they're not only accepting what's happened to them, but starting to recover and then coming to the other side and actually starting to feel a little bit better. I mean, we certainly don't solve all their problems in the, 12 weeks that we're with them, but I think we get them hopefully on the right path and they start feeling a lot more confident. And I think it's that journey of seeing them go from fearful or angry to a little bit more confident, a little bit more secure in how to take care of themselves and knowing that we've been part of that and helping them. I think for all of us in healthcare, no matter what we do, it's usually we do it certainly because we like helping people. And I think we get to see a very visual change in how we've helped someone. And I think for a lot of people, if you work in the ER, you help that person acutely, but you don't always know what happens to them later. And I think for me, the stress testing element was it's a key part of their healthcare, but I don't ever know the after. And I would wanting to be looking their chart, even though I know I can't, to see, well, what happened to them later? Did they have that procedure? Did they recover? Are they okay? And so for cardiac rehab, we get to know the later. They come back and, visit us, and we all have stories of patients coming and bringing us treats and saying thank you. Years after they've graduated, they come back and visit. And that's my favorite part is the being part of that story for them. And even if they're, not grateful, you helped them, even if they're not going to admit that you did. I love that part. I just think it's the reason that we all continue to do what we do.
Yeah, that's wonderful. And I think the confidence, like you mentioned, that's the biggest thing. When they lose that after an event or a procedure, then seeing how they regain it through the rehab, it's one of my favorite things about seeing clinicians like you make such a big difference in such patients.
Yeah.
And speaking of the community, you just had a tour of several state-affiliated societies, and you presented on some of them.
Yeah.
Kansas, Illinois, North Carolina, Tennessee, and I'm probably missing a couple more. What were your presentations focused on?
Quite a few. This year it's one of my many goals. We all have goals of things that we want to be involved in. And I think I always say when I get the opportunity, I'm really strange in that I love public speaking, which is, I know, a strange thing, but it's one of my favorite things to do. And I obviously know I love cardiac rehab. So I always tell states, if I get the opportunity to do public speaking about cardiac rehab, you've just completely made my day. So when someone asks me to come and talk about cardiac rehab, I'm always like, yes, it's always a yes, because I enjoy it so much. But I got to go to, I think 5 states this year. And every single one of them, I learn so much. I might be there to present on something, but I end up getting so much out of it because not only is every state organization run in a very unique way, and I always am trying to steal ideas for my own state organization of how can we run a better conference. Mm-hmm. Just the way speakers present, I love watching the different styles of the way people present. I love the questions that you hear because you do hear a lot of the same struggles. It doesn't matter what state you're practicing in. We all struggle with a lot of the same things, and knowing that you're not alone, I think, is my favorite part of a conference. And when you go and you hear that another site is also struggling with this, it makes you feel like, okay, we haven't had all the answers yet, but we're not the only ones that are still trying to figure this out. And I think that's empowering. And, it's good to commiserate sometimes and say hey, these are the things that are really hard. And I'm not the only one that's frustrated with this, but also I love ideas. So if somebody else has even a clue as to how to try to make things easier, I would love to hear it and implement it in my center and try it. And, I love the idea of change. And I think, every time I get the chance to talk, I talk about how change makes people uncomfortable, but that's not a reason not to do it. And so when any speaker is talking, usually part of their talk isn't just about sharing knowledge, but it's usually sharing an idea that you should think about trying, something that they have seen work. And I think a lot of times we write a lot of those ideas down in our notebook, we have great intentions, and then we go home and it just becomes too overwhelming and we just keep doing the same thing, even though we had this thing written in our notebook. And so I think it's a call to action for a lot of us when we go to state conferences or if we get to go to a national conference. Of don't just write those in your notebook, but bring them to life, throughout the year, and at least try one idea every year or one idea every quarter. And, it doesn't mean that idea is always going to work, but at least you tried it. Keep trying on new things. I think that's the hard part of healthcare is there's so much change that we have to do that any change that we're doing on our own feels like too much. It's like, oh, I've already got all these other things that I have to adapt to. And now you're asking me to add another one. So yeah, that's kind of my takeaway every time I leave a conference is we're all trying to do that. We're all trying to improve. It's just how are we going to go about it is the hard.
And I imagine you've had dozens of conversations with your colleagues at all these different events. So what are the maybe 1 or 2 challenges that you keep hearing about, or just what comes up in conversations again and again?
I think what I usually get asked a lot of questions is sort of the how do we do more with less? Staffing is always a central barrier for a lot of people. They'll say, I want to do that, but we don't have enough staff to. We don't have enough space too. So those end up being a lot of the creative solutions. And a lot of the answers to some of those solutions are if you're trying to solve that problem without making any change to the way you operate, that's why you can't do it, because you're trying to make it fit within what you're currently still doing. They'll say, well, I can only have this many patients in a class, or I can only monitor this many people, or and usually I will flip the script and say, but what if that's not a barrier anymore, because that's not a limitation. What if you don't have that as your limitation anymore? And then people, we'll get a little defensive, right, when someone suggests we change something. But
right.
I think usually it's trying to do the amount of work we have to do in a day between filling out our ITPs and just taking care of our patients and the logistics of running a class and getting all those people in and out and all of the things that have to happen in an hour. It's hard. It's really hard to think about adding one thing to the agenda of a day. So I think looking at what you do and trying to take away the things that aren't essential, like, are you doing this just because you've always done it, or is it bringing value? and trying to look at like what you do in a class or what you do in your program. Do you have to do that? Are those forms absolutely necessary for the patient to fill out? Do you actually look at them? Like those kind of things, those kind of questions. Well, you've always had them fill it out, but is it really necessary, or could you save time by having them do something less and give more time to an activity or some type of interaction with the patient that's actually valuable? Because that's the hardest thing, is finding time to actually spend with the patients to make it meaningful. So I think the question I usually get is the logistics. Like, how do I do all the things you just suggested in the time that I have in my day? And it's, you got to cut something else out. You have to, because we all only have the same maybe 8-hour day, or you may have a 12-hour shift. We only have that 8 hours to do the same amount of work as everybody else. So how do you carve out the time for the things that are really important? Because I think we do unfortunately spend a lot of time doing things that don't add value because somebody said we have to do them. And I question a lot of those things. Like, why are we doing this? Is it something we absolutely have to do? Could we consider eliminating it? And that's probably the theme for a lot of conferences, where people will raise their hand and say, at my facility, and then they list all these barriers. And some of the barriers are the answers. I'm like, you just told me what you need to change, but you're using it as a reason that you can't do it. So sometimes listing your barriers, you just come up with your solutions.
Interesting. Yeah, I guess that's why you're such a pioneer. You question practices that have been in place for a long time, maybe before you even joined the program, and then being curious of how else it can be done, how things can be streamlined, and it opens up and frees up time for doing things better. So that's, curiosity is important.
Yeah.
Well, challenges aside, what's maybe one exciting thing on the horizon or something that's new in cardiopulmonary rehab that you're personally excited about?
Gosh, there's so many things. I think, at the facility level, the idea that, we can offer, whether it be hybrid programs or virtual cardiac rehab, I think that's really exciting for a lot of programs. I think a lot of us are still trying to figure out the how. So the idea of expanding our services to not only offer traditional cardiac and pulmonary rehab, but virtual cardiac and pulmonary rehab is very exciting. I think there's so many things that are being developed at the national level that you can get involved in. I'm a big proponent of getting involved in AACVPR or your state organization, volunteering on a committee, but they also offer a lot of things, whether you're going to get certified, whether you're going to serve on a committee to do like Day on the Hill advocacy work. They have so many things to try to teach you if you wanted to do a quality project in your department because there's something that needs to improve, but you don't even know how to get started with that. They offer a quality cohort. So there's so many things if you have time to go and look at the resources at both your state and the national level. There are a lot of resources out there. I think for most of us, we just get so overwhelmed because there's so many things that we don't know where to start. We don't know what project to take on first. And so for most of us, we just feel like frozen. And I think the idea of too many choices is sometimes is part of the problem. And so usually the best solution is don't worry about doing all the things. Just literally pick one. Literally pick one, because just starting with some small change or some small project and taking that on and seeing it from start to finish, or even if you started it and you realized a bad idea, you still learn from that. And that's still something to be celebrated. You can still do a poster on that and say, we came up with this idea and it totally bombed and you shouldn't do it at your facility. And here's why. I still think that's great, right? Like I want all my projects to end with a bow and like we came up with this great idea and these were our amazing numbers, and that's not the reality of whether it's actual research or just a quality project. The reality is many things don't work and there's still something to be learned from that, and being vulnerable enough to share that with the greater community of cardiac rehab and pulmonary rehab is valuable too. We all want to be like, oh, learn from us, we did this great thing, but I think there's plenty of things we've tried that totally didn't work out the way we thought. Clinical work is the same way. So I think just sharing of ideas, getting involved. I think for most of us, the idea of getting involved in one more thing is too much. But my experience has been the more I've said yes to things and put myself in positions where I feel like I don't belong, that kind of imposter syndrome, I've learned so much from it. And I love networking with people because those people might have an answer to something that I'm struggling with. And once I feel like we've made a connection and I'm willing to share my ideas, I feel like people are so willing to share with me too what they've tried. And it makes me feel less alone in the struggles that our program might be encountering that somebody else along the way is encountering that. So like if you're thinking about doing virtual, there's got to be another program that's also trying to do that. Like you can connect with them. So yeah, I think there's a lot of exciting things happening in our field for sure. I think there's more attention on cardiac and pulmonary rehab than there's ever been. I've seen it in my own hospital administration, in my own health systems. I'm seeing it, at the state level. I'm seeing it at the national level. I think we're doing a better job of tooting our own horn and promoting our field and talking about it and raising awareness. I think there's a lot of work left to be done on that, but we shouldn't be the stepchild. We shouldn't be siloed in our hospital. Nobody knows cardiac rehab exists. Every time I go to a conference, I ask, have you ever been in the cafeteria and say, I work in cardiac rehab, and someone says, oh, I didn't know we had a cardiac rehab. That's such a common. We've all had that. Everyone shakes their head when I say that at a conference, and that's on us to change that. Like, we have to be more vocal about what we're doing in our programs, because usually when you talk to people, they're doing amazing work, but the only people that know about that amazing work stay in the walls of that, department, and they're not sharing it and, within their own facility or their own system as much as they could. And I think that's probably the only reason that I get more invitations is I'm obnoxiously loud about what we're doing. And so sometimes people will for some reason ask me, and I'm like, hey, I'm doing the same things you're doing. I'm just usually sharing it a little bit more, just because I found it to be a great pathway to get a lot of yeses. My system is really supportive of cardiac and pulmonary rehab. They really value it a lot, and I think that's very empowering to feel like, hey, we're important too. The cath lab isn't the only important healthcare part of that patient's journey. And I think when you feel that value and you feel seen, it empowers you to try to take on new projects. And I certainly know our hospital isn't the only hospital out there doing amazing things. I think when you talk to people, they're just providing the most excellent care, but they just maybe need a little bit more attention. They need the spotlight shined on them too.
I'm actually wanted to ask you about, so you're doing cardiac and pulmonary and then SET.
Yes,
all under one roof at MacNeal. How does that shape how you think about patients who fall across more than one of those categories?
Yeah, I think as we've added each of those service lines, we've seen that not that we're learning about a totally new patient, but essentially we're seeing some of those same risk factors all the way across. Certainly our cardiac patients have pulmonary issues. Our cardiac patients have vascular issues, and a lot of them are the same patients. You might see a patient that you have previously treated in either cardiac or pulmonary rehab now in your department for that same service. I think we've all experienced that, and that's something we actually look for. So if we enroll a patient in cardiac rehab, for example, but I also notice that they have a diagnosis of COPD, we will put a notation on their chart that when they finish cardiac rehab, are there any other diagnosis that they should be considered for as far as their future treatments? Is there anything they would benefit from? We want to make sure they know we have those additional services available to them if they need it.
So your team has been building out a frailty-focused strength training program.
Yes.
What drove that decision, and what does that look like in practice?
Yeah, we're always looking at basically the patients that we don't reach or we don't see to fruition. I think we really try to see every patient, not only to get them enrolled, but also to get them to graduate, right? Our perfect scenario is somebody comes 36 times and they get the whole program, and on paper that's the design that we all follow, but we all know that there's those patients that fall through the cracks. Either they never sign up or they come once and never come back. And so we started looking at what are some of the patients that are more likely to drop out, and I think a lot of programs could probably speak to that. They'll say, oh yeah, women are less likely to sign up, or younger people are less likely to sign up, and one of those demographics is patients who would be defined as frail. They're much more likely to either not sign up for cardiac rehab in the first place or to not follow through and finish all 36 sessions for a variety of reasons. But our traditional program, the way it's designed, clearly isn't meeting their needs entirely. So we started looking at what else could we be doing to try to better engage those patients. And, I went to a pre-conference at the National with Dr. Ozemek about 3 or 4 years ago, and that was one of the topics. And we were really interested in doing something, but I think we needed a little bit more structure around how do we go about doing something like this. And so just the idea of trying to assess the patient, identify which patients really need this, and then also what are you actually going to do with them that's different. And I would say we're still very much on that journey. We're trying a lot of different things, but it's been really interesting to not just say, yeah, frail patients don't do as well, and we mention that, but we're saying, no, we're gonna try to do something different with these patients, and instead of focusing really entirely, our time with patients is very cardio focused. Most cardiac rehabs, it's entirely treadmills, bikes, new steps, that's where they're spending their time. And we're finding a lot of research shows it should be the opposite, that a lot of patients really would benefit from more strength training, not only in the gym, but at home. That when we talk to them about, hey, you should be walking 30 minutes a day at home, or using your bicycle at home if you have it. We're pretty good about telling patients what they should be doing outside of rehab, but we don't often encourage them to do much strength training. And I think it's a huge miss. When I first started here 100 years ago, we weren't doing any strength training. And so that was one of the first things I wanted to do. I was like, hey, I think we should add like 10 to 15 minutes of weight training at the end of every class. And that was like the craziest idea. And we've had that component to our classes. We do 10 or 15 minutes of strength training at the end of every session when the patients come. That's just our standard. And so to increase that even more, we're adding additional classes that they can go to that really coach them on how do you do strength training at home, giving them resistance bands so that they can take those home with them, and kind of putting our guidance and saying, in real practice, we want you to take this band, these are the exercises, we're going to do them with you, and then we want you to do them at home. But then while you're in rehab, you might be doing your treadmill or your new step, but I also want one of your modes to be going and working with weights. Not just during the time that we do it with you, but doing a part of it on your own. I want to see if you can do it on your own, because if you can't do it in class, you probably aren't doing it at home. So trying to hold them to, the idea of doing some, foundational strength training in the gym with us so we can see, but trying to be a little bit independent, because the whole goal is to teach them how to do it on their own. And then we're there if they have questions, we're there if they need us to show them again and again how to do the exercise. And then they'll get that standard strength training at the end of the class that everybody does. But again, that was already being provided, and they still weren't that engaged in the material. So we're seeing some good numbers so far. We're seeing those patients, their adherence rates, their dropout rates are going down, meaning they're more engaged. I think that's a great sign. We're starting to see like their 6-minute walk test scores a little bit higher. So I certainly don't think it's the answer to everyone's problems, but I think just the idea again of what is your traditional delivery and how can you change that for certain patient populations. It feels like an impossible task because we're already asked to do nutrition education and psychosocial screening, and we have to really address every problem that the patient has somehow in an hour, plus the 15 other patients that are in there. It's kind of a crazy job that we have in cardiac and pulmonary rehab. But we also have so much time. Like we have 36 hours with these patients, which is 33 hours more than that cardiologist probably sees the patient in a year. They maybe see him 3 times a year. We get to see him for 36 hours. So we also have a lot more time with our patients. And I think sometimes we forget that. Like other disciplines are not seeing their patients 3 days a week. So we need to, I think, be more creative in the time that they spend with us, making sure what they're doing is valuable. They're not just going over there and hitting the cruise control on the treadmill for 15 minutes and doing the same thing they did session 3 as they're doing session 32, because that happens a lot. I think one of the things we don't do really well with exercise programming is progression. I think most of us do a brilliant job, target heart rate and or RPE, and excellent. But then we don't really progress them. They kind of hit the cruise button and don't always push as much as they could, especially if they aren't used to doing something. We're like, oh, that's okay. You do this instead of saying, yeah, you've never used that machine before, all the more reason to try it today. So the idea of comfort and making the patient a little uncomfortable is part of our job. And that's hard because you want to make them happy, but they're not here to feel comfortable. They're here to get better.
Right. And it's interesting, in my conversations with cardiac and pulmonary rehab managers and just EPs as well, the strength training and resistance training is something that comes up every time, and it's also growing in relation to cardio work for sessions. And yeah, like you said, progression, once you see like why they're doing what they're doing, where they're going to be in 3 weeks and 10 weeks, what they're working towards, and also making the exercise prescriptions more visual, more engaging, so that they're more confident doing them on their own.
Yeah, totally. I think engagement is the key. They need to feel like you're giving them some feedback. And I think if we're not regularly telling them their progress, we're pretty good about connecting with our patients, but I want to make sure there's substance behind the feedback. We shouldn't just say you're doing a great job just because they're coming. Like, we sometimes have to shine a light and say, actually, whether their goal is to lose weight and their weight has been the same for the last 4 weeks, or their blood pressure is still kind of high. Like, sometimes we have to share that the progress has stalled. Be a little bit of the bad guy and make sure that we're honest with the patients about the stall that maybe they're having. That's okay. Like, they're not going to have a perfect result at the end of 12 weeks. We have plenty of patients that don't make as much progress as they would want. But if they understand maybe why they're still not, hitting their goals in that area and what they need to continue to change, there's still a chance they could make that progress in the future. Our opportunity after 3 months, I always tell patients that's not the end of your healthcare improvement. Like, you didn't spend 3 months getting out of condition. You're going to take a lot longer than 3 months to get into condition. And I think that's an eye opener for a lot of patients. I would say for most patients, you probably spent longer than 3 months being sedentary. So it's going to take more than 3 months to get conditioned. And I think just getting them to understand that the time they're spending with you is just to get started. And I think a lot of us approach it that way, but reiterating that to the patient over and over again, that they should be using the time that they're in cardiac or pulmonary rehab to develop their skill set, and that they're like in a training environment to learn new skills, rather than rehab sounds like fix me and then I leave it. I think that's part of our messaging is off. We call it cardiac rehab and pulmonary rehab, like we're going to fix them and then they're done. And I think we need to maybe coin another term that it's definitely more like developing a new skill set. It's more behavior modification than it is rehab, in my opinion.
I agree. And because you're teaching them those new skills so they can continue and build on the exercise habit after they graduate, go into phase 3. And then it's also important to arm them with tools and with the knowledge to carry on after they stop coming to the facility. So
yeah, 100%. Easier said than done, but it's important.
That's true. Well, that's a problem we're trying to solve as well with our platform. I want to shift gears and ask about, I know you're pursuing a doctorate at UIC.
Yeah.
And you're also the course director for the new AACVPR CCRP exam prep course.
Yeah.
So what do you think needs to change about how we train and credential the next generation of APs, and how continuing education just helps your day-to-day work at MacNeal?
Yeah. Well, I think one of the most interesting things my experience has been in pursuing the doctorate is I've gotten almost no questions about what I'm learning, what I'm doing, or content. But I get a lot of questions about, like, what are you going to do with that? Why are you doing it? Right? Like, we want a defined end result. If I was going to become a nurse, I would get my nursing degree, and then I know I'm defined as now being a nurse. That's very clear. But I think getting a doctorate in exercise physiology, the definition has always been like, you're going to go into academics. And so people know me as not academics. So they're like, why are you doing that? What's the and I found that to be a very interesting question. I'm like, okay, I think it's been a fabulous experience. It's certainly very challenging to do while still working, but I also don't think there's ever a bad reason to further your education. I think it, just advances your skill set in every way, because for me, a lot of education is about critical thinking, and it's about how are you going to approach complicated problems and providing you with those additional skills. So yeah, I think being able to demonstrate that exercise physiology can be more than just working in a cardiac rehab or working in stress testing. Because I think we are boxed in. A lot of us feel like I've hit a ceiling and this is the only thing I can do. Like, especially in healthcare, if you're a non-nurse, there doesn't seem to be the same pathway or journey for growth. And I think what I'm a big advocate of is all of us, whether you're a nurse, whether you're an exercise physiologist, whether you're a respiratory therapist, I think we all should be working together as a team. And all of us, in one way or another, if we have leadership skills, should have the opportunity to advance clinically and advance leadership-wise. And so for me, I think it's opened up a lot of doors to continue to look at not only new opportunities within my organization. I've been able to take on another hospital cardiac rehab within my own organization and continue to hopefully see more and more cardiac rehabs open instead of close. I think that's one of my many personal missions, is we should be opening cardiac rehabs everywhere and pulmonary rehab everywhere because there's so few of them. We shouldn't be closing them because that's what we see sometimes in healthcare facilities. We don't make as much money as, the cath lab, and so we're the first to get chopped, and yet we're the thing that's keeping you out of the hospital. So we have to remind people of our value. I also I like education, and so I like to be involved in giving back and teaching. Been able to be adjunct faculty in the past, and so I think it's really helped with my ability to do teaching and academics. Personally, one of my favorite things to do is to grow my ability to do public speaking, and I think having a doctorate, there's a lot of skills that are transferable just in terms of providing education, connecting with people. So I think it's helped me in all of those kind of intangible things that sometimes are hard for people to put their finger on, like, what are you going to do with this? They want an answer, and and I've been kind of oddly quiet about saying what am I going to do with it, because people want me to have an answer the day I enroll, which I thought was really, really funny. They were just, a lot of people were very uncomfortable with the idea that I was going to do it, and I was like, well, I'm not asking you to pay for it.
Right.
So it was really funny, but I think the more people that pursue it, I think there's a lot of things in our field that, credentialing wise, that we're working towards to make EPs credentialed in the same way that we see other disciplines, so that, salaries and things like that can be more appropriately allocated, because we all know if we work in this field, that's an area that has to change. For us to be sustainable. We're just asking for equality, really. We want to be paid the same as, nurses and RTs, and equality is not a threat to anybody. And I think that would be a great thing to continue to shed light on, and makes people uncomfortable. And I always warn them, I'm going to bring you an idea or two that might make you a little uncomfortable, but we're not taking away from anybody's pot. We just want to be part of the conversation. So yeah, that's definitely a passion point for me, is to raise the value of the field of clinical exercise physiology, for sure.
Yeah, I think there's no change or growth without encountering something that's uncomfortable. So that's a prerequisite in my mind. So I agree with you.
I forgot to answer the second part of your question, which was the certification. I think is kind of perfectly aligns with what the messaging should be about every cardiac and pulmonary rehab, which is that all those disciplines, whether it's a nurse, an exercise physiologist, or an RT, we should all have the same competency to provide the care. And I think the CCRP certification is kind of the stamp that says, yes, you might have a slightly different background, whether it's, again, the nurse, the RT, or the EP. We have a slightly different background in our education, but essentially the care we're providing should be identical, no matter who's in the staffing model that day. And the certification demonstrates that you have the skill set and the education and the skills provide the cardiac rehab that the patient is expecting. And so I think that's a great messaging for hospital administration to understand, that like all of your staff carry this certification, which means they're all competent at the same level. And so it's just really like a level set for everybody to be on the same page. And so we believe passionately in it. At my facility, all of our staff carry the CCRP certification. And I think it's a very attainable, achievable mark that anybody that works in our field can do. It's not an impossible task. It's a very achievable but also important thing for people to be considering adding to their.
Okay, that'll be interesting for our listeners to learn more about that program. What's the scope of the program, just in terms of time commitment, or a couple of words on what it would take for someone who's interested to?
For the certification?
Right.
So the certification, you're required to have a baseline degree, either could be a nurse, RT, or exercise physiology. And then you have to have the clinical hours. They want you to have experience in cardiac rehab. So I believe it's 1,200 hours of cardiac rehab experience. This particular certification, the CCRP, is a specific cardiac rehab certification. There is a pulmonary rehab certificate, but this one, CCRP, is for certified cardiac rehab professional. And so you have to have 1,200 hours working in cardiac rehab, which is a lot. It means you didn't just start yesterday doing this. But with that experience, you have the knowledge and skills that are going to be asked, the questions that are asked on the exam. And so we all like a study guide. We like some kind of a model that we should be following, so we know what content is going to be available. And I think nowadays most of us are learners that want to learn by more than just a book. And so CVPR came up with this virtual certification course where there's 8 modules. So for each section of the test, whether it be a nutrition section or exercise prescription section, there's a faculty that has developed, really robust content to review like most important things in each section. So there's a module that they can do on their own time, watch it as many times as they want. There's some corresponding quiz questions to try to make sure we're getting you thinking of that content in that way. And then they've also added a live study class, which is really cool. So you actually get to interact with at least 2 or 3 of the faculty. So of the 8 modules, the faculty have each agreed to attend a live session where you actually just get to go through some case studies, talk about why these are the best answers. We're not going over the actual test questions because there has to be a separation of church and state, so to speak. So they're going over just the content, the information you need to know from each of those sections, and making sure they highlight the important areas that you should be studying. And if you go through those modules and you're like, I know this stuff, you're ready to take the test. And if there's certain sections that you feel weaker in, then those are the areas you review a little bit more before you schedule your exam. And then you apply to take the exam, you get approved, and then you can schedule it similar to some other certifications at a testing center. And then pass your tests and you're CCRP certified. So that's kind of the process.
That sounds very useful. Sounds like anyone in cardiac rehab would benefit greatly from going through it. Absolutely.
Yeah, and I think hospitals should support it. I think sometimes people quickly will say, oh, my hospital won't pay for this. But I think if you make a case for competency, that's the buzzword that every hospital administration understands. When you speak competency to them and saying this is a demonstration of competency for the staff, I think you have a lot more buy-in from hospital administration because they understand in every discipline what that means. And cardiac rehab is no less valuable in having competent staff providing it. And I think you're just demonstrating how competent your staff already is by putting those letters after their name.
I agree. Betsy, I had a couple of questions about just technology and tools. Should we go into that at all? How do you think about technology's role in exercise prescription? What problems does it actually help solve, and where does it still fall short of providing real solution?
I mean, I think we probably don't use technology enough in our cardiac and pulmonary rehabs. I think we sometimes use handouts and education materials that we've had for 5, 10, 15 years because somebody else gave that to us. So I think coming up with new material that's engaging to patients, but I think it can't replace the interpersonal. I think you should be handing out stuff that is personal to you, that you are aware of, that you agree with, the things that you practice in your clinics. If you have certain exercises you teach your patients, those should be the same home exercises we're encouraging them to do. Adding a personal element, showing them rather than just saying do these things and handing it to them and you never actually interact or address it. I think it's less likely they're going to engage with the content. So for me, it's a blend. Like we sort of have to practice what we preach. We should be doing those same things with our patients in class that we're asking them to do at home. And I think it's that repetition of like whatever exercises you value. And to me, the technical skill of like which exercise, how many reps and how many sets, I think we get very focused on that. But what about just making sure the patient actually understands the why? Making sure you do both of those. Like, do they really understand why you're giving them that handout and asking them to do it is just as important as how technically perfect you wrote that exercise prescription that they're never going to do. You got to do both of those things really well because otherwise if the patient's not buying into it, it doesn't matter how great our prescription is. So I think the interpersonal connection that we're making with our patients, it always has to be the kind of cornerstone of what we do. And then those technical skills of the exercise prescription become, a great tool. And I think for some programs, why we're hesitant to learn new ways of doing the exercises, not all programs have a ton of exercise physiologists on staff. They might only have 1 or 2, and they might have several nurses or respiratory therapists that didn't have the same education background in exercise prescription. So they might not feel as confident to veer off the what they know and try something new. And I think that's all the more reason why we not only want to have a variety of staff, but we also want to be certified. so that we bring those skill sets and we bring that knowledge, and we continue to ask all of our staff to be competent in every area of delivery, from reviewing medications and making sure we're knowledgeable on those to the exercise itself. And it shouldn't just be like one person or two people on your staff that feel confident talking about exercise, because that is the cornerstone of what we're doing with our patients every day. So I think challenging all staff, no matter what their background is, that they become competent and comfortable in delivering exercise, interactive exercise with our patients is important. The doing with them, we do the exercise the last 10 or 15 minutes of class with the patient. So, our staff's up there teaching weight training. And I've heard that from a lot of programs, and I think that's the greatest way to get the patients to actually follow through, is to do it with them. If you tell them to go do it over there, but then you're sitting there doing, your ATP reviews, it's hard to get them engaged. So doing it with them is the best way to get them to actually engage, my experience.
Yeah, absolutely. That's something we've been hearing as well. If once you show them, then even if it's just a text prescription or a picture that shows the exercise, they've done it before with you, they're more confident and more likely to do it on their own, even if it's at home, away from the facility.
Yeah, I think it's taking the materials, which are plentiful, there's so many resources, and then putting a personal touch to it so that the patient feels like you designed something for them and didn't just give them the same handout that you give everybody else, because none of us like that. We don't like to have a cookie cutter solution to anything. So it's helpful to try to make it more personal to the patient, especially if they maybe mentioned a goal to you, something that they want to work on getting stronger for, being able to do. That's your window to motivation. They just told you something that they want to get better at, and now you have a reason to tell them all the things they have to do in order to achieve that goal. So that's usually what I'm looking for, is you got to give me your why. Once you give me that, that's like, okay, now I've got my in, and I'm going to hold on to that as I coach you through what I want you to do.
I've had a conversation about 2 weeks ago with a EP at a cardiac rehab program at, I'm not going to remember which hospital, I just have so many of these calls, but he was telling me about a patient that wanted to get back to tennis after his event.
Uh-huh.
And so he had a particular goal, and the EP was actually excited about building a program specifically for strength in upper body and all those elements that are involved in tennis. And that made the patient really follow it here, and he completed all the sessions because he knew what he was working towards. And
yeah, that's your in. I mean, to me, like, if you can discover that early in their cardiac rehab experience or pulmonary rehab experience, something that they want to do that they can't do or can't do well, that's usually the motivator. You have to give them something they can visualize, that they can see themselves improving to be able to do. Sometimes it needs to be a much smaller goal than what they envision. They might give you something that you're like, that might be a little unrealistic right now, but breaking it down into something that's a little bit more short-term that they can accomplish towards that long-term goal. For all of us, right, in life, that's the way you accomplish anything, is chopping it up into smaller bits and working your way through that. So, yeah.
Maybe last question,
Sure.
Betsy, and I appreciate your time. What does your team at MacNeal do that you wish more programs would dare to try or implement, that you have seen work well? And just any final takeaways for cardiac pulmonary or just clinical exercise physiologists listening to us?
Yikes. That's a big question. I mean, I think I'm blessed to work with a group that just is highly engaged. I think, for lack of a better word, they're all personality hires, right? Like, they all just have this gift for connecting with their patients. I think they're extremely passionate about what they do. And I think for the most part, whether they want to or don't want to, they know change is always part of our conversation. And I think the thing at my facility that we really are very prideful on is the idea of innovation and the idea of change, and that whatever is working today may not work, in 2 years. And we can't get too comfortable in what we're doing right now. And I know, at a staff meeting, I've always got a long list of the things I want to try, this or that. And my poor team is like, oh, Betsy, we're still working on your list from last month or last quarter or last year. But I think they always stay open to the idea of change, and they stay open to the idea of trying new things. And I think that the programs that I've interacted with across the country, because there are so many good cardiac rehab and pulmonary rehab programs out there, and usually the ones that are the most energized are the ones that are doing those things. They're going to a conference or they're watching a webinar, they're taking an idea and they're trying it. Sometimes it crashes and burns, and sometimes it's widely successful. And then they're sharing that. They're sharing the success and saying like, hey, this is what we did. It could just be sharing it at a table at a conference with the other people that are at your table, or it could be presenting it in a poster or whatever. I think programs that I've seen that are what you would label as like a really successful program are usually the ones that are always trying new things and that are willing to share their ideas and stay connected with others. I think that that is, to me, the mark of a great program. It's, of course, we want to have great outcomes, and I think most of us have tremendous outcomes and wonderful stories to tell about our patients, but I think there's not always a platform to share it. You know, we don't all get this great opportunity to talk about what we're doing, and I certainly know I'm one of many, many people that should be sharing their stories and inspiring, you know, others. Is what I always take away from every conference is the inspiration I get from other programs and other ideas, and try to write them all down and bring them back to my team. And they do the same when they go to conferences. They come back and I see their notebook and they're like, hey, I've got this idea. And I love that. Like, bring us an idea. It should always be the team that is driving the change. It shouldn't be driving from administration of your hospital. It should be you bringing your ideas to your administration and saying, we need support. We need whatever in order to make this idea happen. I think that's the best marriage for a program, is you bringing your ideas to administration instead of waiting for them to come to you and tell you what changes you need to make, because they don't know your program the way you do. So I think that idea of being engaged, I think the idea of rewarding your staff for their engagement, finding ways to recognize them with more than just a pizza party, really putting some thought into how we can reward them, whether that's sending them to a conference or creating a clinical ladder for them to be engaged, but providing them with opportunities for advancement is really important. And I think those are some things that we really try to do here at our facility. Is we want to try to retain the best people for as long as we can, or help them towards their next journey, and seeing them be successful, you know, in their career, and having us be part of that journey is, I think, really important to me.
That's a great answer. It's been a fantastic conversation.
Awesome.
Thank you so much for being our first guest on Prescribe. The colleagues in the cardiac rehab community will find this very useful. And for anyone who wants to modernize exercise prescription in their program, you can find us at workoutlabs.com/train. And if you're a clinician doing interesting work in the space and would like to be a guest on our interview series, reach out and we would love to have you.